Hey, y'all. I want to talk to you real quick about induction of labor. Um, Technical definition: chemical or mechanical initiation of uterine contractions before spontaneous onset. So, this mom is not in labor yet, and either the doctor has ordered it or she's ready to be in labor, and the doctor has said okay. And we get in labor induced, we get labor started by chemical or mechanical means, which we'll talk about here in a moment. So an elective induction means that she is asking for it. She's chosen to be induced. Um, if she does not have a medical reason to be induced, so maybe preeclampsia or gestational diabetes, she has to be 39 weeks. Um, we call if a mom is getting to the end of her pregnancy and she's like, please let me have this baby. I just want to go into labor. I'm just ready to have this baby. We call that TOT, tired of totin', and she wants an induction. Um, Side note about this: inductions are more painful. We are inducing contractions that are stronger, oftentimes when they are chemically enhanced. Okay, so just a side note to moms that are considering getting an induction: if they would prefer to not get an epidural and labor naturally, usually don't recommend choosing an elective induction in that case. Okay. Um, but anyway, when we are looking at inducing moms, we oftentimes will get a Bishop score to evaluate objectively how likely she is to go into labor, how likely an induction would be successful, especially quickly, hopefully. So the table in your book shows you exactly how we score the cervix, essentially, to get the Bishop score. But it's things like, is she already dilated some? Is the cervix effaced some? And is the baby engaged? Things like that. A score of 8 or more is considered favorable, which means like her body's already kind of getting ready and she just needs a little extra push over the edge. So that, of course, would mean that she's favorable for an induction. We use Bishop scores, but it's not to say that if she has a low score, they would not induce her, because we see it all the time where they bring a patient in and her Bishop score is not high, but we just know that it might take a little longer to get labor started for her. Indications and contraindications. So you can look in your book. I'm going to check actually really quick while I'm on here with you and see if these are the current page numbers, because you know that our book version just got updated. So some of the pages that you see on the slides may not be exactly the same, but this one is. So indications for induction, so this would be a reason that the doctor would order an induction, are of course all sorts of medical conditions, right? um, Including, we mentioned hypertensive disorders, preeclampsia, but also chorio, so maternal infection. And then there are indications on the fetal side, like diabetes, which we talked about, which is more that the diabetes is affecting the fetus or could affect the fetus. Post-term pregnancy, and if IUGR, so the baby's not growing like it should, and it's probably either because of a condition in the mom or the placenta is not functioning as well as it should, and it would be safer for the baby to go ahead and deliver and help the baby grow outside the womb rather than keep the baby in and it be malnourished, is essentially what it is. Sometimes it's related to oxygen, sometimes it's related to nutrition, but usually related to something having to do with the mom or the placenta. An induction would be contraindicated if the baby is in distress. So in any induction, we're watching the fetal heart tones very, very closely. And if the baby seems to be in distress or progresses to appear in distress, which of course, remember, we're looking for accelerations, which are a good thing. We don't want to see decelerations, especially late decelerations. And those would be with the variability going flatter and flatter as well. Those would be concerning signs that the provider might be like, okay, we're not trying this, or we're going to stop trying this and just go ahead and go to C-section. Okay. Other things might be kind of obvious reasons not to induce. Basically, they are all reasons that we would do a C-section instead. So fetal malpresentation, the presenting part is not the occiput, or placenta previa and prolapse cord and things like that. We're going to C-section for those. So now, cervical ripening is what we often do, especially if the Bishop score is low, and oftentimes if it's the mom's first baby. So if the Bishop score is higher, or it's the mom's second baby, often we'll start with oxytocin instead of cervical ripening, because the cervix may already be kind of ripe in those cases. But a lot of times, especially for first-time moms, we need to ripen the cervix a little bit. Cervical ripening will soften and thin the cervix. Again, just kind of gets the ball rolling. Okay. So some chemical agents that are cervical ripening include prostaglandins. These are Cytotec, Cervidil, and prostaglandin gel. Interesting note is you may have heard before that intercourse can help begin labor. It's not necessarily the physical act of it. It is the hormones that are involved in it. So sperm contains prostaglandins. And what happens is when that sperm is up near the cervix and is allowed to sit there for a while, it works just like, although a more mild version, you might say, it works just like our medications that we are using to help soften and ripen the cervix. If, let's say, she has an orgasm, then she's got lots of oxytocin pulsating too. Oxytocin is the happy hormone, the pleasure hormone. And these that I've just been mentioning are the chemical agents that we use to get labor started. And it's also this couple bullet points down, the physical recommendations that we might give to help labor get started on their own. So I skipped over a little bit, but I just wanted to kind of tie those concepts together for you in case that helps you with your remembering them. So prostaglandins are cervical ripening agents, and we usually just place those up next to the cervix for about a 12-hour period and see what happens. Sometimes we can repeat it again if they need more ripening still. So then mechanical dilators include the cervical ripening balloon. That is what is in this picture here. It's basically like a Foley balloon on either side, and we gradually add more and more fluid to it until it's squeezing the cervix, and it physically essentially forces it open. But it's slowly and over time. It's usually not too painful for the mom, and we just a lot of times that'll just kind of get the ball rolling there. Laminaria is actually a seaweed, and it does something similar, but the cervix has to be open a little bit, and you actually put it in the cervical opening, and it basically expands over time because of like absorbing fluid there, basically. So physical recommendations for getting labor started, as I mentioned, are intercourse, nipple stimulation, because nipple stimulation produces oxytocin. Excuse me. And remember, oxytocin is the natural form. The hormone name for Pitocin that we use. Pitocin, the artificial form of oxytocin, to basically induce or strengthen contractions. So it works directly on the uterine muscle. But it is naturally occurring in our bodies, and it's encouraged. It is produced at higher levels in nipple stimulation or even orgasms. We might also recommend walking. Walking can be good. It won't do anything if your labor is not already kind of beginning, but it might kind of help encourage it if you're in early labor. And these upright positions are going to help encourage the baby to continue to put pressure on the cervix, and any pressure on the cervix once it's already, ready to be beginning to open will be good for it. It will help it encourage to keep opening. And then last here, amniotomy. We also call it AROM. It's artificial rupture of membranes. So this is for augmentation. So it's very common for a doctor to break a mother's water, as we would call it, commonly called breaking your water. So we do not do this, though, if she isn't already starting in labor, and especially if the baby's head is not well engaged, because there's a very high risk that as we break the water, the fluid rushes out and it could bring the cord down with it, and the cord could be pinched between the baby's head and the cervix. It could completely prolapse down through the cervix as well. And it's just a big risk of artificial rupture of membranes if the baby is not well applied to the cervix already. If the baby is, then of course all the fluid above the baby, including the cord, will kind of stay up there until delivery. So we want to be careful not to rupture the membranes too soon for that reason, and because as soon as we rupture the membrane, there's a big risk for infection, and the clock starts ticking. We're on it's like a time sensitive thing. We want this baby to be delivered for sure within 24 hours of the water breaking. But we like 18 hours even more. And if it's been 18 hours and labor is not very imminent, we're going to be starting antibiotics and kind of head off any possible infection risk at that point. So those are the main things. Our chemical agents are prostaglandins, also not specifically listed on here, but also oxytocin. So prostaglandins are for cervical ripening. Oxytocin is for inducing contractions and strengthening contractions. So I hope this was helpful to you for learning a little bit more about induction of labor.